like, first of all, to say thank you to both speakers this morning and introduce the moderator of our panel, Justin Stebbing, a bit of a polymath. So, Justin, I'm not sure you were totally aware that you're chairing this panel, but thank you for coming. And thank you so much for our speakers this morning. So, we've got 10 minutes of discussions now on what you've just heard about the menopause, about testosterone and TRT. So, it's open to you for questions. Thank you.
And I'm going to be a little bit rude and start myself. I learned a lot in that talk, by the way. Obviously, I'm a professor of oncology by background, and when you see a nail, everything becomes a hammer to me. And I was always worried about cancer risk, and I felt like you sort of glossed over that. And the problem is, if you give someone a carcinogen, the lead time to developing cancer is at least a decade. Could you just reassure me and help me understand something about that?
Yeah. Prostate issue. We've just been to the Testosterone for Life meeting in Amsterdam, over the weekend, and we've had speakers from all over the world. And as far as prostate cancer is concerned, Dr. Abraham Morgenthaler was there, and he is one of the world's experts, as well as Mo Nero from Houston, Texas. They have looked through the literature, and there is no evidence of a case that has been given testosterone replacement and developed prostate cancer, apart from unmasking. So the clinician tries to make sure there's no cancer there at day one, and they will miss some, so you follow them with a PSA at 0, 3, 6, and 12 months. And I did an audit of my patients, and we found 3 patients out of 500 in an age group.
That sounds lower than the background risk of prostate cancer.
And if you look at the longitudinal studies, there's a study in the Lancet Diabetes and Endocrinology, Wallace et al. 2016, shows prostate cancer reduces on testosterone replacement therapy. If you go back to the seminal paper with Huggins back in the 1954, and there are no cases that he talks about. There is one case who had prostate cancer, and you gave them testosterone, and the alkaline phosphatase increased.
Brilliant.
So there's nothing.
Okay. Questions from the audience, please. Do you want, young lady, just a minute? Yeah. Please. Yeah, please.
Sorry. You talked about estradiol replacement and importance for osteoporosis in men. I'm wondering how you diagnose the optimal amount for each patient, and also what about progesterone?
In men?
Yeah, in men. I'm just wondering, I've heard it's associated with
Yeah. To be fair, we don't really measure progesterone in men, and I don't think you would commonly. You can use it as an adjunct marker for fertility, but it's not great. I don't think I'll be using that for any diagnostic reasons. For estradiol, if you're just simply getting aromatization, then largely we tend to just look at the ratio of the two. And if your patient is generally asymptomatic and has no estrogenic symptoms, then unless their estrogen is wildly high, above, 180, 200 or something. And even with that, I'm not particularly bothered if they feel great and their testosterone level's fine. I think the issues come when the estrogen levels are creeping up or the testosterone levels are dropping down and they don't remain in balance. But I think for testosterone-estrogen ratios, generally in clinic, we look at the clinical picture rather than necessarily the biochemical one, because it tends to lag a little bit behind.
Question at the back.
So do you see any difference in ethnicity of the reference values? And if so, if you tell us that normal is good, how can we calculate the normal if we don't know what's the reference?
Right, so this is complicated, and as Sir William Osler says, medicine's an art based on science, so it's an art. So we've recently been looking, there's a gene polymorphism within the androgen receptor exon 1, which actually is a CAG repeat and it varies in the population between 9 and 35. And if you measure that, you'll find out that people from an Afro-Caribbean background have a higher sensitivity androgen receptor. So the lower the repeats, the higher the androgen sensitivity. People from European are in the middle, and people from the Far East are more likely to have an insensitive receptor. So we have been developing a blood test, which is a testosterone CAG repeat ratio. So the higher your testosterone and your lower CAG repeat, you will have a higher sensitivity of androgenization. So that's how you can work it out. And we've also shown that when testosterone is given, if someone has a high CAG repeat, which is low sensitivity, they don't respond unless you get the testosterone in the higher normal range. So it's much more than what we've done. The normal range is what we use for in general practice, not general practice, but in general practice to go by, and these are from the societies. And the majority of the societies cut off at 12, but you'll see some patients, and there's evidence from Germany, if 15 to 12, you'll get people with reducing libido and more fatigue, and they may be the ones with this genetic polymorphism. So at the moment, we're at the cusp of trying to find out and tailor each individual's treatment to the level of testosterone they need.
In the middle, thanks.
Yes, my question is about possible evolutionary causes of the decline in testosterone. And Professor George, you said so much so quickly, so I may be hallucinating in my memory of what you said. But did you suggest that perhaps the decline in testosterone was there to maybe make older people more interested in being a good grandfather than chasing young?
Well, that's always a possibility. That's always a possibility. But as the father of andrology said, there's no limit to the testosterone level that you can have with treatment. So it's now social, and whether evolutionary things are related to that. But it's probably disease and obesity are the main causes of the lowering of testosterone in life as you accumulate different diseases.
I think we've got time for one more question just at the front. Thanks.
Hi, I inherit some patients from the US, and they've been on long-term TRT, and you know in the US they like to overdo things. So two things I see quite often. One, their hematocrits are quite sky high.
Yeah.
Two, they inject relatively frequently. So when I went to some training, saying, once every 2 weeks, once every month, these people are on it, twice a week. And I wanted to know, is there any consequence of that? Because they then undergo phlebotomy, so therapeutic phlebotomy, they take off the red cells and stop the hematocrit that fits into their blood. So I don't know, is that something we see?
Well, we see them from the end point usually. The commonest presentation is the man comes because his partner wife wants a baby, and because they've been on high-dose steroids, they have no sperm, and it can take 6 months or longer for sperm to recover, and usually if they don't recover and they are infertile and need other treatments. So that's number one. Number two is the hematocrit. Yes, the spiking gives you, it's a normal thing that testosterone stimulates bone marrow to produce red cells. That's one of its major functions. But if you keep it within the normal range, largely you will keep the hematocrit below 54%, which is the guideline. So you allow it to go up a bit, but if it's above 54%, we don't know whether it causes a problem. We know in groups of patients with heart disease, smoking, whatever, there is an increased risk of thromboembolism potentially, or the Framingham study, the big showed cardiovascular. So we always use 0.54 as the cutoff. They seem to be addicted to testosterone, just like they are to opiates. And it's very difficult to lower their dose. And the only motivation is the end product of a child and the wife or partner staying with them. So it is a big problem. So any of these people now bodybuilding, it's going to be a flood of people saying they're infertile, infertile, subfertile.
Can I just say we do actually tell our patients to take twice a week injectables, because it reduces the HCT. Don't care. But it reduces the HCT.
For time, we'll maybe continue this. Just for time, do you want to introduce the next speaker? Thanks so much for both.